Hello everyone, how are you all? Thank you so much for joining our today's session. As you know that we are going to discuss cardiology class 2 tonight. So we discussed the syncope cluster last class, right? Did you guys go through the syncope cluster again, the like video? Do you have any questions? So we did the syncope. It's one of the very important cluster for your AMC clinical exam. Tonight we are going to do the palpitation cluster. Okay, so let's start. Palpitation cluster will also cover a couple of other cluster, like sometimes palpitation, patient may not present with palpitation, rather they can come to you with nervousness. Okay, so palpitation and nervousness both will be in a same cluster. So what are the differential diagnosis? So as always, you always do the differential diagnosis first, and then we make a format for a cluster, and then we just cover the cages. Okay. Now, in case of differential diagnosis of palpitation, your most important system is the cardiovascular system. So it could be ischemic heart disease. It could be mainly any arrhythmia. So any arrhythmia that you know, ventricular tachycardia, atrial flutter, fibrillation, any of those can cause palpitation. Also, sometimes myocardial infarction or ISD, means ischemic heart disease, can also cause palpitation. Hypertension can cause it, or valvular heart disease can cause palpitation as well. In case of CNS, CNS is not directly associated with palpitation, but still we try to rule out, mainly if the patient presents with nervousness. So always rule that out. So CNS, stroke or TIA, epilepsy, infection, trauma, tumor. So always in CNS, you have 4 or 5 differentials: trauma, tumor, infection, stroke, epilepsy. So these 5 are always in CNS. Endocrine is very important differential diagnosis, especially hyperthyroidism. This is an exam case. Then sometimes hypoglycemia can present with palpitation or even nervousness. Pheochromocytoma is also very important. Anemia can cause palpitation or tachycardia. Anxiety disorder is very important to rule out panic attack, stress disorder, or anxiety disorder in anyone presenting with palpitation. Sometimes menopausal women can feel palpitation or even nervousness or quite anxious. So if it's like a 47-year-old lady coming to you with feeling nervousness, you should always rule out menopausal symptoms or at least perimenopausal stage. Now, this too is very important. So sometimes medication induced palpitation can be there, like someone is asthmatic and she just took a lot of salbutamol and then can present with palpitation. So medication induced is very important, but very important, like excessive tea, caffeine, or coffee, also recreational drugs can result in palpitation. Also, alcohol withdrawal can cause palpitation. So excessive tea, coffee, recreational drugs, alcohol, these are all very important. In your exam, if you want to remember, like arrhythmia is very important, then hyperthyroidism is the exam case. Anxiety disorder or panic disorder, not very commonly asked, but still you should know about it. Excessive intake of caffeine or coffee is also exam case. So as you can see, there is a lot of important cluster here. Sometimes even menopause or perimenopause usually comes with nervousness. So these are the main cases that very important from this cluster. Now, now you know about the differentials. Let's go into the history. So as always, we will always follow the same history for this cluster. So if we know this say, one format of palpitation cluster, then we can actually finish 4 or 5 cases. So in case of history, someone with a palpitation usually presents very acutely. Okay, so you always need to make sure this patient is hemodynamically stable or not. So just like previous class, you remember one thing that you should always greet the patient very, very politely. So say that, hi, this is Dr. Arshan, one of the doctor here. I understand from the notes that you are having racing of your hearts. How are you feeling now? So then patient will say, yeah, I'm okay, doctor. Or sometimes patients say, I'm still having that. So whatever it is, reassure the patient. Please don't worry. Now that you are here, we will try our best to manage your symptoms. Now, before I ask you in detail about your symptoms, I would like to make sure that you are stable enough for this type of history. So go ask the invigilator that, dear invigilator, I would like to know if my patient vital is stable for further history. Examiner says, yes, go on. And then you come back to the patient and say, John, would you please tell me a little bit more about what exactly happened today? So open-ended question. So patient usually will give you some of the information that you need to know. Otherwise, you need to ask these questions specifically if you don't get information from the patient. Sometimes patient can say, what do you want to know? So if the patient says in that way, that means they will not give you any answer. You need to ask each and every questions. Okay, it can happen also. So you need to know that when did it started? Did it start suddenly or gradually? And what exactly patient was doing at that time? Very important, that is it for the first time or not. Most of the patient will say like it's not first time, maybe he or she had it for like 3 or 4 times recently. Now you need to make sure that you ask those details of the previous episodes. So would you please tell me more about those previous episodes? What were you doing at that time? How long each of those episodes last? And how did it stop? Like, did it stop spontaneously or you need to do anything else? So these are the main thing you want to know from the previous episodes. Then ask about anything makes it better, anything makes it worse. Is it continuous on and off? Now already you asked that how long did each episode last. So you don't need to ask it again. Then the main important thing, always make sure you start with the presenting complaint. This patient presented with palpitation or racing of the heart. So you should always start with this question, not anything else. Once you start, then always HOPC should be in detail. So you need to ask everything that you can from the patient about the presenting complaint. All right. After that, go to the associated symptoms. So along with the palpitations, did you feel or have, like, mainly like if the patient is still having palpitation, then you can ask, do you feel? Or if the patient's episode has been already stopped, then you can ask, during these episodes, did you feel dizzy or lightheadedness? So very common associated complaint, someone having arrhythmia, most of the time they also feel kind of dizzy or lightheaded. So it's very important associated symptoms. Then you, to rule out the CVS and CNS cause, you can start asking questions from here. So any chest pain, shortness of breath, any nausea, vomiting, or excessive sweating. Nausea, vomiting, excessive sweating, that's for myocardial infarction. And chest pain, shortness of breath, obviously, these are also for myocardial infarction. So that will cover your CVS cause. As you can see here, ISD, AMI, hypertension, you don't need to ask now. Arrhythmia and valvular disease. Valvular disease, you don't need to ask now as well. So mainly you need to rule out ischemic heart disease or MI. Rule out CNS causes, so any headache, any problem with vision or speech, any weakness, any loss of consciousness. So that's your main two differentials, CVS and CNS. Then come to the endocrine. So for hyperthyroidism, you usually ask one or two questions. So any recent change in your weather preference? Now sometimes patient can ask, what do you mean by that? So then you need to specify that, do you feel excessively cold or excessively hot? these days. Patient with hyperthyroidism, they cannot tolerate excessive heat because they already have this heat intolerance. Vice versa happens with the hypo, they cannot tolerate cold. So you can always ask in that way. But better to ask like, have you noticed any recent change in your weather preference? Any change in your bowel habit? Any change in your body weight? So bowel habit, patient with hyperthyroidism will have diarrhea and also they will lose their body weight. So that's your hyperthyroidism. Then come to the pheochromocytoma. One question for that. So any episodic headache, sweating, or flushing of the face. Patient with pheochromocytoma usually have this episodic onset of flushing, sweating, and headache. They also get pretty like very high blood pressure. So always try to rule that out in here. For hypoglycemia, did you skip your meal today? Then other differentials. So for anemia, again, you can ask the diet of the patient, or mainly you ask, do you feel tired or fatigued these days? Rule out infection because that can also cause tachycardia or palpitation. So any fever, cough, runny nose. Electrolyte imbalance can cause it. So any vomiting or any diarrhea. So that's your main differential diagnosis. As you can see, there is a lot of differential in this case. So mainly in the exam, differentials comes. So you have to keep in mind that you are going to do these steps. Go to the SADMA, so smoking and alcohol history, followed by tea, coffee, and recreational drugs. So mainly you will say like, do you smoke or drink alcohol? How about tea or coffee? Most of the patient will say, yes, doctor, I drink like about 5 cups of coffee a day. So that's one of your positive points. Any chance or any recreational drugs use. Ask about any other past medical history. So any history of diabetes, high blood pressure, or any heart disease. Any family history of sudden death, especially related to heart or any sudden cardiac death. Social history is very, very important. Why? Because you want to rule out panic attack or any anxiety disorder. So, who do you live with? Any stress at your home? Any stress at your work? Okay. If this patient is a female, then always rule out menopause. So, ask about the last menstrual period. Ask about some of the menopausal symptoms. So, any hot flash, any do you feel irritable, frequent mood swings, or dryness in your down below. So that's your menopausal symptoms. Mainly patient with menopausal symptoms, they will obviously say that they had their last menstrual period about more than a year ago. Now patient can have hot flushes, anxiety, irritability, frequent mood swings, palpitations. Then also they can have dryness of their vagina. So all are very pretty like very common symptoms for menopause. So if it's a female, you need to ask that. Clear? So just to recapitulate, in here you will start with the like greeting with the patient, reassuring the patient, followed by hemodynamic stability. Then you start with the history of presenting complaint, which is mainly palpitation, associated lightheadedness or dizziness. Then come to the differential CVS, CNS, endocrine, mainly hyperthyroidism, hypoglycemia, and pheochromocytoma. Then others are anemia, infection, electrolyte abnormalities. Lastly, finish with SADMA, tea, coffee, recreational drugs. And very important is to rule out any anxiety problem. Okay, if it's female, then menopausal symptoms. Clear, guys? Any question? Now, you don't need to ask the patient to tap over the table. It's not needed. Many of the patient gets like irritated when you ask them to tap on the table to see the rhythm. It's not needed, but if you want to do that, that's fine. But it's not mandatory to do that. Those who are in the Facebook, if you guys have any questions, Please write it in the comment box so that I can have a look and then I can answer you. Now the PEFE, physical examination from examiner, that's same like how we did in our last class. So nothing has been changed. It's the same format. Okay. So for cardiology, we will follow the same PEFE throughout our all the clusters. Let's start with the supraventricular tachycardia. Now, if someone has, like, if any of you haven't been in our last class, please make sure you do that so that you can also go through the PEFE. So, starting with the supraventricular tachycardia, you are a junior HMO in ED. A man came in with thumping or racing heart and giddiness started today. Your task is to take history from the patient, PEFE, ask investigation from examiner, and explain diagnosis to the patient. Most of the time, it will not be your task. Usually, in this case, you need to ask history from the patient. You need to ask investigation from examiner. When you ask investigation, especially ECG, examiner gives you ECG, and you need to explain ECG to the examiner and explain diagnosis to the patient. So that's mainly the case that comes in the exam. So what are the positive points can be there in supraventricular tachycardia? So patient will have like kind of palpitation or racing of their heart. They can also feel dizzy or lightheadedness. Sometimes that can also lead to shortness of breath. Patient had 3 episodes previously. All of them started suddenly, lasted about 2 hours, and then stopped all of a sudden. Patient also takes 6 to 8 cups of coffee a day. So that's one of the very important risk factor. No smoking or alcohol, no previous or family history of heart disease. Patient is also anxious personality and patient is also stressed. Now, remember in one of the class I said sometimes you can get more than one diagnosis in your exam. So you can get supraventricular tachycardia. Now, why this patient having supraventricular tachycardia that you need to find out. And also sometimes palpitation can be associated with other condition. Like if someone is stressed and quite anxious personality, they can have palpitation as well. So you need to explain everything when you explain diagnosis to the patient. Now look at this ECG, what you see here. If you remember one thing, in the exam, you will not get too much time to read the ECG. So you have to be very quick. Always it's easy to know because someone having palpitation, obviously you should look at lead 2. You don't need to give too much concern about this chest lead because it's unlikely to be MI, but it can be, but not very common. So you should always start with the common thing first. So common is arrhythmia. So you should always look at the rhythm strip. In the rhythm strip, if you look at here, you can, excuse me, sorry. So you can have a look that this is a regular rhythm, right? So every RR interval is regular. Then you look into the PQRST. If you look at here, you can see it's very narrow, right? QRS is very narrow. A normal QRS should be between 1 to 3 small square. Now, this one is like very, very narrow, even not one small square, I would say. So you can see narrow complex tachycardia. And especially, you cannot see any P wave here also. So there is no P wave, only this wave is your T wave. So you can find out T wave, but no P wave. So absence of P wave, regular rhythm, narrow complex tachycardia, that's your supraventricular tachycardia. Okay. So Supraventricular tachycardia is very easy to diagnosis, very easy to diagnose. So always have a look clearly in the rhythm strip. You will just by the look of it, you will know that this is SVT. So in SVT, what you are looking for, you will look for RR interval. You can see it's regular. When RR becomes regular, it's obviously not atrial fibrillation or flutter. Okay. Now, one thing is left. It could be sinus tachycardia or it could be SVT. So in sinus tachycardia, you should get P wave. When you don't get P wave, that becomes supraventricular tachycardia. And also you can see the narrow Hello guys, can you hear me? Sorry, I think somehow the network dropped. Good. Okay. So I was discussing about the supraventricular tachycardia. As you can see here, always look at the rhythm strip when a patient presents with palpitation. When you see it's regular, you can always rule out atrial fibrillation. Sometimes flutter can be, but flutter you should get this sawtooth appearance, which you cannot see here. Now, if it is not a atrial fibrillation or flutter, then you should think about either it's a sinus tachycardia or supraventricular tachycardia. Then you look at the P wave. You cannot see any P wave in here. That means it's SVT. On the top of that, you can see this narrow complex as well. So that's your supraventricular tachycardia. As you can see here, this is the typical of SVT. Regular RR interval, narrow QRS, absence of P wave. Now, explaining the ECG to the examiner is very, very important. So how we can do that? You can say, now if it's needed to be done to the invigilator, then you can say, dear invigilator, I would like to describe the 12 lead ECG of my patient, Mr. John, a 25-year-old gentleman who presented to me with a sudden onset of palpitation. The ECG shows, now in the ECG explanation, it should be in a good format. It should not be in a haphazard way. So you should start with the rate, rhythm, then always you know that this is P wave followed by QRS complex and then T wave, right? So start with the P wave, then QRS complex, then ST wave, then T wave, and lastly QT interval. Okay, so it should be always in this way. So in here you can say the ECG shows heart rate, whatever heart rate you get, you can easily say it to the examiner. Now you will not get time to measure heart rate in the exam, so it's always very good to remember. So if you look at here, in here, like let's say one small square is here and like one, two. So one big square, that means five small square. And in here you can see seven, right? Seven small square. The trick is here, like to get the heart rate, we divide 300 divided by number of large square in between RR interval. So let's say this one, if there is one small square, one large square between two RR interval, heart rate will become 300. If there is two large square, then heart rate will become 150. If it is three large square, heart rate becomes 100. If it is four large square, heart rate becomes 75. Now, just remember in this way, because Just when you want to tell about the rate, you don't need to be totally perfect. If you just go near to it, that's fine. All right. So use this formula in the exam because it will save a lot of time. So if there is one large square, then heart rate 300. If two large square, heart rate 150. Three large square, heart rate 100. Okay. Now, if it's atrial fibrillation or flutter, mainly fibrillation, because you will not get a regular RR interval, you cannot use this formula. So at that time, forget about the rate. You don't need to bother with the rate. They will not going to fail you for that. So in here, the ECG shows heart rate 150 beat per minute, regular in rhythm, absence of P wave, narrowed QRS complex, no ST wave changes, T wave normal in size and shape, QT interval normal as well. So you have to explain in this way. The ECG shows heart rate, whatever you get, 150 beat per minute, 100 beat per minute, regular in rhythm. What about the P wave? Absent P wave, narrow QRS complex, no ST wave changes, T wave normal in size and shape, QT interval normal as well. So you see that there is a format in here. So you should always remember this format when you explain. Don't, that's why I say don't bother with that. It's not like one small square. I would say it's not even one, it's a little larger than one. So it should be in between 300 and 150. So if you just say that it's 200 or even 250, it should be fine. There are also other way to do that, but I don't want you to get confused in this little thing. Don't worry on that. Sometimes if you just use 1500 divided by number of small squares, that also will give you the heart rate, exact heart rate. But don't bother with that. Just give a approximate one, that should be fine. So explain it to the patient. Your last task is very important, that how you explain these palpitations or these ECG findings to the patient is very, very important. Many candidates uses a lot of medical jargons and try to explain ECG. No, you don't need to teach ECG to the patient. Even there are lots of doctors who cannot read ECG very properly. So how come a patient can understand ECG, right? So try not to do that. Give a very simple explanation so that they can at least tell it to their partner. Okay. So explain, John, look, this is the electrocardiogram that was taken when the nurse put those leads on your chest today. The lines that you can see here are the result of the electrical impulses that conduct in your heart. Now let me draw a picture so that you understand what's going on. So draw a heart and say that this is your heart. Your heart has electrical impulse to pump blood to your body. In your case, there is some abnormality in these electrical impulses, causing your heart to beat faster than normal. And that's why you are having racing of your heart. And as your heart is not getting enough time to fill in your brain, sorry, as your heart is not getting enough time to fill in, your brain is also not getting enough blood. And that's the reason you are feeling giddiness or lightheadedness. We call this condition supraventricular tachycardia. There could be many reasons behind it, like it could be due to structural heart diseases, Sometimes it could be problem in your heart valves. Sometimes it could be medication, recreational drug intake, thyroid dysfunction, infection, salt imbalance, excessive tea, coffee intake, etc. Now, one thing you can say, supraventricular tachycardia can happen even in a normal, healthy heart as well. Or sometimes it could be due to any underlying heart condition. So you'll explain what is supraventricular tachycardia, and then you can say, look, John, there could be many reasons of this sort of palpitations. Could be due to a structural heart disease, could be due to problem in the valves, or sometimes a normal heart can also have this sort of palpitation. Other than supraventricular tachycardia, the palpitation that you had, it could be due to other causes. Then you can say, whatever positive finding you will get, if you find out excessive tea, coffee, then you will say, also from your history, I have found that you are having 6 to 8 cups of coffee a day. That's one of the very common risk factors of having frequent episodes of racing of the heart like you had today. Sometimes, if you are under a lot of stress like you are at the moment, can lead to palpitation. Other than this, it could be due to, then you give all the differential. Could be due to infection, but you don't have any fever, cough, or any other symptoms of infection. Could be thyroid problem, but you don't have heat intolerance. You don't have any loss of body weight or diarrhea. Could be recreational drug intake, but you're not doing anything like that. Could be salt and water imbalance, but you don't have any vomiting or diarrhea. So these are very unlikely. So give all the differential diagnosis and explain in this way. Okay. Now management of supraventricular tachycardia, I have never seen coming in the exam. You should all know the management. So if it's a supraventricular tachycardia, if it's a GP setting, you have to send the patient to emergency department. But first of all, you can try some of the vagal stimulation like Valsalva maneuver. You can ask the patient to close their nose and then breathe out through their ears. That's what is Valsalva maneuver. So close their nose. So ask the patient, I'm going to do a procedure called Valsalva maneuver. So I need you to pinch your nose so that nothing comes out through your nose, and then breathe out through your ears. When the patient do that, they usually stimulate the vagus nerve. Okay, that's one of the things. If that's not possible, sometimes you can do carotid massage, making sure this patient doesn't have any carotid artery stenosis or any plaque. You can also do ice water immersion of the face. So these are all vagal stimulation. You can do any of these. If that doesn't help, obviously the patient needs medication like adenosine. Okay, most of the patient with that like gets better with the adenosine. Even if the adenosine doesn't help, then the last option will be DC cardioversion. This usually happens if a patient is stable. If patient is unstable, initially you have to go for DC cardioversion. But don't worry on the management because it normally it never ever asked in the exam, because in the exam more commonly they ask that how you explain ECG to the examiner, how you explain ECG to the patient. So that's the most important part. Clear, guys? Any question? Because you will use the same explanation in all the other cases as well. Look at the atrial fibrillation case. You can see middle-aged lady comes to the ED with sudden onset palpitation. Same task. One of the tasks in here is explain causes and complication of the condition. So that's like a little new task. Always in the exam, make sure you remember your task. Okay, it's very, very important. If you miss any task, you should, like most likely you will fail. So try not to miss any task. It's very, very important. And do not do any task which is not asked. Many of you will do that if you are not serious enough. Okay, so you have to be very attentive during the exam as well. Like we always do history, PFE, then explain diagnosis. What if PFE is not asked in your task, but because you have been practicing in this way, you just did it like without your intention or without knowing that you are doing this. So that's why you should be very, very careful about the task during your exam. Now in here, patient presented with palpitation, lightheadedness, just like the SVT case. Nothing was positive except patient has hypertension. Hypertension is one of the risk factors of having atrial fibrillation as well. Now, you should always look at the rhythm strip. Looking at the RR interval, you can already know that this is atrial fibrillation. And then you can confirm by looking at the fibrillatory F waves. So you can see the fibrillatory waves. There is no specific P wave that you can see. So how you are going to explain this ECG? Same way. So I would like to describe the 12-lead ECG of my patient, a 25-year-old gentleman presented with sudden onset of palpitation and giddiness. The ECG shows heart rate. Now, in here, if you can't say heart rate, then don't bother with the heart rate. So you can say the ECG shows tachycardia. So you can say just tachycardia. Forget about the specific heart rate because it will be near impossible to do that in that time strain. Okay, so the ECG shows tachycardia, rhythm irregular, absence of P wave, which is replaced by fibrillatory F waves, narrow QRH complex, no ST wave changes, T wave normal in size and shape, QT interval normal as well. So same way, right? But in here, it's irregular in rhythm, absence of P wave. This, this is the main two finding that you should obviously talk about. So explain your finding to the patient. The explanation will be totally same like the SVT. You don't need to say anything extra. Okay, so same. So how we explain SVT? So you can say that this is the electrical record of your heart called ECG. This was taken when the nurse put those leads on your chest. The lines that you can see in the ECG, this is actually the result of electrical impulses that's conducted in your heart. Same explanation, let me draw a picture for your better understanding. This is your heart has electrical impulses, and that helps the heart to pump blood to your body. In your case, there is some abnormality in this electrical impulse, causing your heart to beat faster than normal and also irregular. Now, in here, you'll just use irregular with faster. And that's why you are having racing of the heart, and your heart is not getting enough time to fill in. As your heart is not filling enough, your brain is not getting enough blood. And that is the reason of your feeling of lightheadedness. So same explanation in any of these tachycardia cases. One of your other tasks was explain the causes and implications of these findings. So what are the causes of atrial fibrillation? So you have to talk about all these things. It could be high blood pressure, our patient having hypertension. So that must be the reason of this patient's AF. Could be due to ischemic heart disease, that means heart attack. Could be coronary artery disease, abnormal heart valves, congenital heart defects. So you can say heart defects that you are born with, overactive thyroid gland, sometimes exposure to some stimulants such as medicine, caffeine, tobacco, or alcohol, lung disease, previous heart surgery, or even stress can cause atrial fibrillation. But mainly you should remember hypertension, ischemic heart disease, congenital heart disease, valvular heart disease, and hyperthyroidism. These are very, very common causes of atrial fibrillation. What are the complications of AF? Mainly two: stroke and heart failure. So you have to explain that this condition can put you in several risk factors or several complications. One of them is a stroke. So what happens in atrial fibrillation, the chaotic rhythm may cause blood to pool in your heart's upper chamber, and then it can form clots there. If a blood clot forms, it can dislodge from your heart and then travel to your brain and blocking the blood flow to your brain, which we call a stroke. Are you with me so far? Yes, doctor. The next one, that also in case of atrial fibrillation, if it is not well controlled, it can weaken your heart muscle and then eventually leading to heart failure, a condition in which your heart cannot circulate enough blood to meet your body's needs. Please don't get scared. It's not like that you are going to have it, but it's very, very commonly can happen if we don't control your heart rate by this time. Don't worry, you are in the best hands. We will try our best to manage your symptoms. So always finish with a like a good, polite, gentle, reassuring word. Always your finishing should be very, very good. All right, guys. Any question? Mainly in palpitation cluster, this two is your important case. Other cases we will discuss in some other cluster, not with the palpitation cluster. So someone asked about, can you please explain tap on the table? Now, sometimes I have seen some of the candidates do that, like ask the patient, can you please tap on the table, showing your racing of the heart. Now, sometimes patient can do like this. So that means that this is happening irregularly. Okay, so that can at least give you some idea that is it a regular or irregular palpitation. It's not very important. Sometimes patients don't understand what you are actually asking. Sometimes they become like irritated because if 32 students or like at least even a 16 candidates are just saying, can you tap on the table? So patient will be kind of irritated for that. So don't do that. Okay, no question in someone who in the Facebook. All right. Yes, that's right, Dr. Visna. So that I also heard that many candidates had bad experience with this question. So try not to do that because you don't want to waste your time in the exam. Okay, so it's not mandatory to ask the patient to tap. You will be doing a ECG, you will be doing PEFE, you will know if it's regular or irregular. It's not needed. All right, guys, we're going to do the chest pain cluster, but let's take a 10-minute break so that we can start with a new cluster. In terms of your ECG, you don't need to know any more ECG for the exam. In the chest pain cluster, we will go through MI and pericarditis. That's two ECG is very important, and atrial fibrillation, supraventricular tachycardia, sinus tachycardia. These are mainly important, and the prolonged QT syndrome we did last class. So let's take a 10-minute break. Thank you all. All right, guys, so let's start again. Now, this is the most important cluster in cardiology, which is your chest pain cluster. So very, very important. So what are the differential diagnosis of chest pain? Now, all of you know most of these differential diagnoses, but when it comes to the exam, you will find out there's only two or three differentials are coming in mind. So always make sure you keep this differential diagnosis in your mind so that in the 2 minutes time in the outside, you can remember most of these differentials. So obviously CVS is your main important system in here. So it could be angina or MI, could be pericarditis, could be aortic dissection or aortic stenosis. In case of lung or respiratory system, pneumonia, pulmonary embolism, pneumothorax. Very, very important differential. So always need to rule out any respiratory causes. So pneumonia, pulmonary embolism, and pneumothorax. For GIT, especially any reflux or peptic ulcer disease. Musculoskeletal system could be costochondritis, could be rib fracture. For neurology, mainly prolapsed disc or herpes zoster can also cause chest pain. Psychological is very important, so it could be panic attack or anxiety or stress disorder. So these are your differential diagnoses: CVS, respiratory, GIT, musculoskeletal, CNS, and psychological. So it's a lot of differential diagnosis. Many times only differential come in the exam, so you should be covering most of the differentials if that's the case. So someone having a chest pain, it's a medical emergency, especially if it's a middle age or elderly patient. So obviously you need to make sure this patient is hemodynamically stable. And any patient having any pain anywhere during the exam, you should always offer painkiller to them initially, not after like explaining the diagnosis. Initially, you should offer painkiller to them always. So this will be a little different than how we used to do the cages. So again, this patient will be a like will be a lot of stress because chest pain. Everyone knows that this is not a good thing to have. So patient will be stressed. So make sure you reassure them a lot. Say, "Hi John, this is Dr. Arshan, one of the doctor here. I'm really sorry to hear that you are having chest pain. Please don't worry. Now that you are here, we will take care of you. You will be fine. Before I start asking any more questions, can you please tell me how severe your pain in a scale of 1 to 10?" Patient says, "Doctor, it's 10 by 10. I'm sorry that you are having so much pain. All right, I'm going to arrange a strong painkiller for you, but do you have any allergy to any medications?" "No, doctor." "Well, I'm going to arrange it now. Hopefully, you will feel a little comfortable after the medications." So always offer painkiller if someone having pain. Then make sure you also ask hemodynamically stable or not. It's very, very important in this case. So please excuse me for a moment, John. I'm going to ask my examiner a little bit questions. So, dear invigilator, is my patient vitally stable for further history? Examiner will say, please proceed, or they can say, stick to your task. So, whatever it is, you go to your hemodynamic, you go to your HOPC, which is history of presenting complaint, and then you start question. Thank you so much, John, for waiting. How are you feeling now? Are you okay to answer a few of my questions? Yes. Okay. Can you please tell me more about your chest pain? What are the things you need to know? This is the time you should ask about everything that you learned. So your Socrates will act here. So Socrates means any pain anywhere, we always follow this Socrates. So, oh my God, what is this? Let me erase this. Okay. So in Socrates, you have site. So where exactly is the pain? You need to know. How did it started? So what was the patient doing before the pain started? That's your onset. Character. So how does the pain feel like? So is it a squeezing pain or is like a stabbing pain, sharp pain, dull pain? We need to know that. Radiation. So does the pain go anywhere else? Associated symptoms, we already asked it. Time or duration. So how long you are having the pain? Anything makes it better, anything makes it worse. So exacerbating or relieving factors. And severity. Severity, we already obtained the severity in a scale of 1 to 10. So now if you know that, then you will start asking questions in terms of Socrates. So can you please tell me more about your chest pain? Patient will give you some information, but you need to know these things. So when did it started? What exactly you were doing at that time? Did it comes like, did it start suddenly? Is it for the first time? Is it continuous or on and off? Where exactly is the pain? Can you please point it out for me? Does the pain go anywhere? So radiation. Can you please describe the pain for me? How does it feel like? So we want to know if it's a stabbing, sharp pain, which is mainly positive in pericarditis. Sometimes in case of MI or angina, patients say that they are having a constricting or it's squeezing kind of chest pain. So that's why it's very important to know. Anything makes it better, anything makes it worse. So that's your pain question. Remember, in chest pain cluster, you should ask all these pain questions. It's very important. Then associated, what can be associated with chest pain? So you want to rule out any symptoms of myocardial infarction. So along with the chest pain, are you having any difficulty breathing, any racing of your heart, any nausea, vomiting, or excessive sweating? So that's your main question: nausea, vomiting, excessive sweating, shortness of breath, or racing of the heart. Okay, so this will rule out myocardial infarction. Now come to the differential diagnosis. For the differential diagnosis, start with the severe causes. So you have pericarditis and aortic stenosis. For pericarditis, the question that we ask is that, does the pain get worse when you lie down? Does it get better when you lean forward? Any recent flu-like illness? Patient with pericarditis most of the time comes after a viral flu, so you should always ask that in any chest pain cases. And also, usually pericarditis patient will sit in a way that they will try to show you that they are leaning forward. So you have to get that thing from the patient. Obviously, you need to find out, does the pain get worse when you lie down, and does it get better when you lean forward? For aortic stenosis, we already asked chest pain, we asked about shortness of breath. You can ask any dizziness or sudden blackout. Okay, that will finish your triad. Go to the respiratory causes. For pneumonia, any fever, cough, shortness of breath. You already asked shortness of breath, no need to ask again. For pneumothorax, any trauma to your chest, usually only thing that you need to know, any trauma to the chest recently, or does this patient have any lung condition like asthma or COPD? So any trauma to your chest, do you have any lung condition? For pulmonary embolism, any recent travel to anywhere? Do you have any past history or family history of clot in your legs or lungs? For pulmonary embolism, there is a lot of other questions. We are not going to discuss it today. We will discuss it in respiratory cases. But for pulmonary embolism, main question will be any recent travel. So long travel is one of the risk factor of PE, and also personal or family history of clot is also a very, very important risk factor. So these three is your respiratory causes. Then you have got reflux and peptic ulcer. So you can ask, does the pain has any relationship with food, any heartburn, any bitter taste in your mouth? Okay. So does the pain has any relationship with food, any heartburn or bitter taste in your mouth? For costochondritis and herpes zoster, costochondritis, only one question, that is your chest sore to touch? Patient with costochondritis, they if you palpate over the costochondriac area, you will feel like patient having some tenderness or even sometimes swelling in that area. So that's your costochondritis. So is your chest sore to touch? For herpes zoster, any rash on your chest? Just one question. For anxiety or panic, are you generally an anxious person? Do you worry a lot about most of the trivial things? So you want to rule out any anxiety disorder. So are you generally an anxious person? Do you worry a lot about most of the trivial things? So as you can see here, there is a lot of differentials. So starting with the hemodynamic stability, reassurance, painkiller, asking all the chest pain questions, associated question, ruling out MI, then all other differentials, pericarditis, aortic stenosis, respiratory causes, pneumonia, pneumothorax, pulmonary embolism, reflux or peptic ulcer disease, then musculoskeletal, mainly costochondritis, herpes zoster, any rash on the chest, and lastly psychological. Okay, and then finish with SADMA, stress at home or work, past medical history, family history, and medication history. It's very important in these cases that you ask about past medical history of any high blood pressure, diabetes, high cholesterol, or heart disease. Family history of heart disease is very important as well, and if this patient is on any medication. So always we finish with SADMA, past medical history, family history. Clear? So as you see that this is a very long case. So most of the time in the exam, only thing that comes is history, diagnosis, and differentials. Sometimes they say that investigation from examiner, in which you have to explain the ECG to the examiner and to the patient. PEFE is totally same like before, nothing to add, but in case of chest pain, when you auscultate, do not forget to ask about pericardial rub. Why it's important? Because pericardial rub can be positive in pericarditis. So do not forget pericardial rub if it's a chest pain case. Starting with the pericarditis, 50-year-old tram driver presents with sudden onset of chest pain since 2 hours. Your task is to do a focused history, P from examiner, diagnosis and differential. So sudden onset of chest pain since 2 hours, 50-year-old. So this is a high risk patient. The positive points in the history will be chest pain since 2 hours, aggravated by lying down and deep breathing. So you can find out if someone's chest pain gets worse with lying down and deep breathing and gets better with leaning forward, that's probably pericarditis. Stabbing kind of pain, sometimes radiating to the back and in between the shoulder blades. Not very common, but it can happen. Had a flu-like illness a week before. So this is a vital history. Apart from that, there is no other symptoms. Now, if you look at this ECG, what you find out? In case of chest pain, you need to be careful because you need to look mainly into the limb leads and chest leads. So what are the limb leads you have got? Lead 1, lead 2, lead 3, AVL and AVF. You have got chest lead from V1 to V6. Now, lead 1 and lead AVL, these are high lateral leads. Lead 2, lead 3, and lead AVF, these are inferior leads. And V1 to V6, they are anterior leads. Among the anterior, V5, V6 are anterolateral leads. And also V2, V3, mainly these are septal leads. Not very important to know that, but sometimes it will help you to get the diagnosis. So what you look for ST elevation, right? So it's always start with the V1 to V6. So in the chest lead, try to find out if there is any ST elevation. V1 is normal. V2, now to know if it is a ST elevation or not, you have to know what is baseline. So that's your baseline or isoelectric line. Your ST wave should be in the isoelectric line. When it gets above the isoelectric line, that means there is ST elevation. So in here, there is a little ST elevation we can see, not very prominent, but in here in V3, you can see this is ST elevation. So normally the ST should come here. It should be like this. In V4, again ST elevation, in V5 ST elevation, in V6 ST elevation. So you can see there is ST elevation from V2 to V6. Then go to the lead 1 and AVL. Look at the lead 1. Lead 1 also having ST elevation. Lead AVL also having ST elevation. After that, just to confirm, you look into the inferior leads. If it's a case of myocardial infarction, if you get ST elevation in the anterior leads, you should always get ST depression in the inferior leads. That is called reciprocal change. And that always happens in case of myocardial infarction. If you don't get that, if you get ST elevation in all the leads, then think about pericarditis. So that's why you're looking into the lead 2. In the lead 2, you can see there is ST elevation. Lead 3, nothing much. Lead AVF also having a ST elevation. This is the ST. So now you understand that there is ST elevation almost in every leads. When you get widespread ST elevation, and they are mainly concavity upwards, you can see this is concavity upwards, or I usually say it's a chair shaped. You can see it's kind of chair. If you want to sit here, you can sit. Okay, so when you get this chair shaped ST elevation, then this is mainly pericarditis. Is this clear for everyone? This is very important to understand. So as I said, so what you should get, if you get ST elevation in the chest leads, you can get ST elevation in the high lateral leads, which is 1 and AVL. That's okay, but you should get reciprocal ST depression in the inferior leads. But when you get ST elevation in the lead 2-3 AVF along with the anterior leads, think about pericarditis. Now, in this case, because this patient is a 50-year-old and having a chest pain, there will be some changes in the history, especially at the initial things like hemodynamic stability and what you need to do. We will discuss that in our next case, that what you need to add here. So you explain in here, most likely you are having a condition called acute pericarditis. Do you know what it is? No, doctor. All right, let me draw a picture for your better understanding. So this is your heart. Your heart has an outer covering known as pericardium. When your outer covering of the heart is inflamed, we call it acute pericarditis. Most likely it's due to the reaction of the viral infection that you had a week before. As the covering of the heart is inflamed, it's causing this stabbing type of pain, especially when you are taking a deep breath in or when you are lying down. Are you with me so far? Yes, doctor. Good. Now, John, it could be due to other reason as well. It could be due to heart attack, but your ECG doesn't go with that. It could be due to aortic stenosis. So you need to give most of the differential diagnosis in here if differential diagnosis is the task. If differential diagnosis is not the task, still give some differential just to show to the examiner that you rule this out, but you don't need to explain that how you rule that out. So just give that it could be due to aortic stenosis, it could be due to uh, angina or myocardial infarction, it could be related to gastroesophageal reflux, herpes zoster, but in your case, these are all unlikely. So in that way, you will just like very quickly, you will give the differentials. If DD is not a specific task. If management is a task in this case, explain that please don't worry. Most likely it's not a heart attack. But to confirm my diagnosis and exclude heart attack, I would like to keep you under observation in the hospital. Also, I will involve my senior and also the heart specialist who might want to do some investigation like full blood examination, inflammatory marker, your kidney and liver function, repeat ECG, and troponin. And if needed, they can also order a echocardiogram. All right. If it is confirmed to be pericarditis, then there is nothing to worry about. You just need to take bed rest and some painkiller for your pain relief. Okay, so that's mainly your management in pericarditis because there is no specific management in this case. Any question, guys? Let's do the acute MI, which is very important for your exam. So 55-year-old man comes to your ED with sudden onset of crushing kind of chest pain. Take a history, PEFE, ask investigation from examiner and explain the likely cause of his chest pain and immediate management to the patient. So this is how exam questions comes up. Sometimes they might not give you PEFE in here. Most likely history, investigation, and explain with the immediate management. Even if they give PEFE, in these cases, usually they will give it through a card, which will not waste which might waste like about 30 seconds to have a look. Positive points in this case would be acute onset of severe chest pain, which is crushing in nature, radiating to the jaw, neck, and left arm, and for the first time. Associated shortness of breath with nausea, vomiting. Positive smoking history, no previous heart condition. Now, as I was saying in here, because chest pain in a 50-year-old is a high risk thing, and you cannot just rule out myocardial infarction in these patients. You have to repeat ECG, you have to repeat troponin. Even if it could be pericarditis, we always do this test. So initially, what you need to do in this case, even if patient is vitally stable, you have to follow the approach. So what is the approach? In any chest pain, you have to say, first, obviously, greet yourself, reassure the patient, offer some painkiller, go to the examiner, ask for hemodynamical stability. Examiner might say, just proceed. Even if examiners say just proceed, you should do this first. You would say, dear invigilator, as my patient having severe chest pain, and also he is a 54-year-old gentleman, I would like to take my patient to the resuscitation cubicle, attach him on cardiac monitor, ask the nurse to do an immediate ECG, and followed by I will secure an IV line, take the blood for cardiac enzymes, especially troponin, and if oxygen saturation is low, I will start with oxygen. Your main task in here is to send the patient to the resuscitation room, attach him on cardiac monitor, do a immediate ECG, and send the blood for cardiac enzymes. Oxygen is not for everyone. Only if the saturation comes below 94, then we give it. Clear? So in all these cases, even if the patient is stable, we need to do that. No, as a junior doctor, you can send basic blood investigation. You don't need a specialist for that in hospital. Even in chest pain cases, nurse can send some of the blood test. So that's fine. Okay. Now, your history will be same like before. Only thing that you need to do initially is this thing. Remember that monotherapy is vital for anyone in this age group having a chest pain. So what is mona? Morphine, which you will give during the pain management. Oxygen only needed if patient saturation is low. Nitrate and aspirin. Now these two, if you see that in the exam question, they have given an ECG and it shows like it's a MI, you should immediately give aspirin to the patient and nitrate. So in my perspective, because even when patient comes through ambulance, the protocol is to give aspirin and GTN even during the ambulance time. So you can do that in any chest pain cases along with this, like sending the blood for cardiac enzymes and troponin, you can start aspirin and nitrate as well. It will not harm the patient. Rather, it can save the patient. So you can say, take the blood for cardiac enzymes and troponin and would like to start aspirin and GTN, making sure my patient is not having hypotension, because you cannot give nitrate if it's a hypotension. Other than this, you can give nitrate. If you don't want to give nitrate now, it's fine, but aspirin is a very, very important thing to do, because every second is life-saving for that patient. Every second. And with the aspirin, you can actually save a patient life if the patient is having MI. So that's why you have to be very careful. If it's a 20-year-old having severe chest pain, you don't need to follow this. It's unlikely to be a cardiac chest pain. Most likely it could be pneumothorax in young age, or pneumonia, or pulmonary embolism, mainly related to respiratory. Cardiac chest pain is more common after 40. So after 40, anyone having this sort of pain, you should follow the same approach. Okay, so I would suggest that at least start aspirin to these patients, because when you do that, examiner will be very happy with you, because in every hospital, every GP center, this has been followed. Okay, even when before patient comes to the hospital, patient usually gets aspirin if it's suspicious of MI. So you can always do that. That's totally fine. Okay. Now, your history will be same. So patient will have severe chest pain in the left side, and it will be kind of crushing or squeezing chest pain, very severe in intensity. Patient will say that it's radiating to the left arm, neck, and jaw. Okay. And sometimes patient can have severe nausea, vomiting. Patient can have shortness of breath. Patient can have excessive sweating as well. So these are the main features of MI. After that, now if you are going to give aspirin, you can say that it will make you more protective, doctor. That's fine. Like you can say, like, ruling out any history of peptic ulcer disease. You can do that. That's fine. No, regarding oxygen, we don't give it always, only if necessary, which means if the patient's saturation is less than 94, then you give it. It's not always. Cool. Good. Now look at the ECG. What do you think this patient is having? So if you look at V1, this is the isoelectric line, this having ST depression, right? Also ST depression, ST depression, V4, V5, V6, ST elevation. Go to the lead 1, nothing is there. Lead AVL, ST depression. Lead 2, well, this is prominent ST elevation, prominent ST elevation, prominent ST elevation. So lead 2, 3 AVF having ST elevation. Others are mainly having ST depression. Now, this ECG, I would say, like, normally, even in V4, V5, V6, is very unlikely to get ST elevation in this case, but don't bother with that. When you get lead 2, 3 AVF ST elevation, with that, most of the other anterior leads having ST depression, you can actually call it as an inferior MI. Sometimes we can say inferior lateral MI, but it's not a common thing to have. What about this one? Now your turn. What do you think this patient is having? What type of MI? So if we look at here, we can see that V1 is totally fine. V2, obviously patient having ST elevation. This is the J point, you can see. V3 having ST elevation. V6 having it, V5 having it, V4 having it. So most of the V2, V3, V4, V5, V6. So obviously it could be anterior MI. And then you look at here. So lead 1 and AVL also having it. So it's the anterolateral MI. If you look at lead 2, 3 AVF, these are all good. Lead 3 having some ST depression, that's reciprocal. Okay, so that's anterolateral MI mainly. So that's your anterior lead V1 to V6, and lead 1 and AVL is the high lateral. So if you get ST elevation in chest lead and high lateral lead, it will be anterolateral. This one is also pretty same. Okay. So then you explain what's going on in here. So you say, thank you so much for waiting, John. Based on the nature of your chest pain and according to the ECG, most likely I'm suspecting that you are having acute myocardial infarction or heart attack. Give it little time, give little pause so that patient understand what's happening, because this is a serious condition, right? So give a little pause, like 10 seconds, and then say, I'm really sorry, John, but it's an emergency condition. In this condition, the blood pipe that supplies your heart get blocked by some clot. And as a result of that, your heart muscle doesn't get enough blood and oxygen, and that can lead to a serious complication. Every second we are delaying, you can have serious heart condition as well. Please don't worry, because you came here as soon as possible. We can manage your symptoms, and you are in the best possible hands at the moment. With proper intervention, your problem can be managed very effectively without any serious complication. Now, if the patient comes to you within 12 hours of chest pain, then you give reassurance. After 12 hours, don't give reassurance too much. Because of that, I need to admit you in the hospital, call my senior, and also call the heart specialist for further management. In the meantime, now if you did not give aspirin at that time, then give it now at least. In the meantime, I'm going to give you a tablet called aspirin, which you need to chew only. I already has given you a strong painkiller, and will continue until you feel comfortable. If oxygen saturation comes below 94, I will start you with oxygen as well. If you are having ongoing chest pain, even after giving painkiller, I will start you with another medication called nitroglycerin spray under your tongue. So you just explained the immediate management, right? The specialist might do further investigation like full blood examination, see like inflammatory markers, liver, kidney functions, your blood sugar, lipid profile, and a repeat troponin as well. The definitive treatment of this condition is to remove the clot and restore the blood flow, what we call as percutaneous coronary intervention or thrombolysis. This will be decided by your specialist based on the duration and severity of your condition. In this condition, they will try to remove the clot or dissolve the clot. Okay, so now one of the important thing, you don't need to talk about this in this case, because if they're asking about immediate management, your immediate management is monotherapy followed by sending the patient to the catheter lab for PCI as soon as possible. If it's a rural setting and you don't have much time to send the patient, go for thrombolysis. Okay, but in case of tertiary hospital, we will always go for PCI. So up to that, you can just finish it here. This will be decided by your specialist based on duration and severity of your condition. Once your once the clot has been removed, then there are some of the medications that we might need to start you on. I will discuss in detail about that later on. And I will review you again after talking with my senior. Just finish it there, okay? Because you will not get too much time here. This is a long discussion. So in case of management, you will pass the management task if you talk about monotherapy, and you have to talk about PCI and thrombolysis. Okay, if you don't get time, just at least say the word PCI thrombolysis. Okay, you have to say that because this is a very important thing to do. Any question, guys, with the management? So any patient having ST elevated MI coming less than 12 hours from the onset of chest pain, that patient should have the PCI as soon as possible. So now, Dr. Krishna, how is your the PPT should not be blurry. Check your internet connection, please. It should not be blurry. Okay. Yes, V3, V4, even V2 can be septal, but yes, septal could be mainly V3, V4. Sometimes we keep V2 also, not much. Can I take ECG before giving aspirin? Yes, you can if the examiner gives it to you. So remember one thing, it's not a fault if you don't say that you are going to aspirin initially. If you want to look at the ECG and then you want to give the aspirin, that's also fine. But what if this patient not having a ST elevated MI, it's a subendocardial MI? It can happen, right? So initially when you did the ECG, it was normal. But just after 2 hours, you have found our patient's troponin is sky high. And now, even if you give aspirin, already damage has been done. Now, in rural setting, if it's not like, if the patient comes very early and you have like, the main thing is like when a patient comes into your door, you need to go for PCI within 90 minutes max. Now, if the tertiary hospital is more than 90-minute away, let's say like more than 2 hour away, there is no way you need to send the patient for PCI, just go for the thrombolysis. But if it's very near to you, or like the you can send the patient within an hour, you can try for the tertiary hospital. But basically in rural, they go for thrombolysis because most of the time ambulance needs some time to come here, and then to go to the tertiary hospital, it's more than 2 hours most of the time. Okay. Any question? So PCI should be done within 90 minutes of presenting to your hospital. So there is two terms. One is like up to 12 hours of chest pain, you can go for PCI. But when a patient presents in your hospital, you cannot delay more than 90 minutes. You should not delay. Okay. Dose of aspirin is 300 milligram. That's right, but you don't need to say the dose. Next, angina. You are in a GP setting, a 62-year-old male who presented a few days ago with chest discomfort. ECG done at that time was normal. A stress test was done later on, showed ST segment change in anterolateral leads. Patient had chest tightness during the test. He is a smoker, no history of diabetes. Your task is to explain the test result, short and long-term management. So this is nothing but a angina management. So this patient is not having acute MI, so you don't need to follow the MI protocol in here. So this patient had a stressed ECG done or a stress test done. During that time, ECG showed ST segment change, which means this patient having ischemic heart disease, or you can say unstable or stable angina. So patient having mainly angina. Angina patient is a high risk of having MI if you don't manage this patient. Now your task is to explain the test result, give the short and long-term management. So explain what is going on. Say that, hi John, it's nice to meet you again. How have you been so far since we last met? So you already should know the patient because you have sent the patient for a stressed ECG. So if you already know the patient, you don't need to introduce again. So then you can say, hi John, it's nice to meet you again. How are you feeling today? How have you been since we last met? Yes, doctor, I'm fine. So I can see that you had your test. How did that go? Did you have any discomfort or anything at that time? Yes, doctor, I was having some chest tightness at that time. All right, don't worry. Let me explain what we have found from your test. If you don't understand anything, please let me know. So, John, when you did the stress ECG test, we have found some changes in the ECG, and also you had some chest tightness. Combining all those, most likely you are having a condition called angina. Do you know what I am talking about? No, doctor. All right, let me explain. So, this is your heart. The angina is the name given to the chest pain or discomfort that comes from your heart when it is short of oxygen. Your heart is supplied by some blood pipes called coronary arteries. And in this condition, these blood pipes gets narrowed due to deposition of some fatty substances. And as a result of that, when you do some exercise or any exertion, your heart can't get enough oxygen, and that's the reason you feel chest discomfort or pain. That exactly happened during the test because you were running in the treadmill and you were doing exercise and your heart was not getting enough oxygen and you started to have chest tightness. Can you relate it now, John? Yes, doctor. So see what I have just done. I actually correlated the patient's symptoms with the patient condition. Now patient will understand why I had chest tightness. Now that's a very important thing to do because if as a doctor you don't inform the patient or explain the patient what's going on, how they can manage their symptoms. You have to always correlate their symptoms with the condition you are talking about. Then they will understand the problem. They will also try to manage it because not only medication can help, patient himself can help as well. So if a patient is not helping themselves, whatever medication you are giving, it's not going to work. So they should understand what's happening. And you have to always correlate their symptoms with their condition. So then again say, please don't worry, it's not an uncommon condition. Millions of people are suffering from this. But unfortunately, it can lead to serious complication like heart attack. And that's why it's very important to follow a healthy lifestyle to prevent any further progression of this condition. Regarding the management, I'm going to start you with some medication, aspirin to prevent further clot formation, beta blocker to improve the heart condition, statins to lower down your cholesterol, and a spray called nitroglycerin, which you need to carry all the time. Whenever you feel chest pain, you need to give a spray under your tongue. Mainly not under the tongue, patient can just spray in the mouth, that's fine. So you need to spray this nitroglycerin whenever you are having a chest pain. So explain why you are giving the medication. You have a lot of time in here. So why you are giving aspirin, beta blocker, statins, and GTN. This needs to be given in every patient having angina. Also, along with this medication, you need to follow a healthy lifestyle. Please try to cut down alcohol to a safe level, mainly 2 standard drink per day. Try to maintain an ideal body weight. Avoid smoking altogether. Please take healthy balanced diet. Please do some exercise, ideally 30 minutes brisk walking at least 5 days of the week. Try to avoid stressful works. For further management, I am going to refer you to a cardiologist who will do further assessment and management as well. Most likely, you might need to have an angiogram. In angiogram, they insert a dye through a very tiny rubber-like blood pipes, or you can say like, just in a very easy way, say that in angiogram, a dye will be inserted in your body and that will go into your heart blood pipes to see the severity of the obstruction of the blood pipes. So in angiogram, a dye will be inserted through your body to look at the severity of your arteries condition. In very easy way, try to like at least say that what is angiogram. Angiogram means that normally what happens, so they put a dye through mainly in the femoral veins, and that dye goes into the coronary arteries, and it can show that how much obstruction is there. And depending on the level of obstruction, and if it's a bivasal or trivasal artery obstruction, the management will be either stenting or a bypass surgery. Now, you don't need to explain this much to the patient. You will just say, most likely, the specialist can go for an angiogram in which they will insert a dye to look into the severity of the condition. According to the angiogram result, next step will be decided. They may want to go for stenting, so they can put a stent into those blood pipes to keep the arteries open, or if it's very severe obstruction, your specialist can also go for an open heart surgery. Please don't get scared at this time. Nothing is sure now. It all depends on the angiogram result. Please don't get afraid. You are in the best hand. Always reassure the patient. It's very, very important. Now, I want you to know, if you again have this sort of chest pain, please follow the angina action plan. So angina action plan means that if you have prolonged pain, even after taking rest, take the nitroglycerin tablet under your tongue or the spray. Wait for 5 minutes. If that is not relieved, notify a friend or relative that you are having a chest pain. If even after 5 minutes your chest pain persists, repeat the dose again, wait for another 5 minutes. If not relieved, call ambulance immediately, take a third dose, tell the ambulance that I'm having a heart attack. This is very important to do. I'll give you reading materials about everything that I have described, and I will review you once the cardiologist has seen you, once the cardiologist has reviewed you. So finish with the 4R. So I'm going to give you some reading materials. I will review you regularly. Again, once the cardiologist has seen you, please come to me so that I can follow you up. Please make sure you follow the angina action plan in case you are having the sort of chest pain again. Okay, so finish with the 4R. So in case of angina case, your main thing is you should explain what is angina and why it is serious, gives this medication, talk about healthy lifestyle, talk about further management, especially angiogram, and talk about angina action plan. Clear everyone? Any question? Any question, guys? Okay. So the next case is angina due to anemia. Not very, very important, but again, you should know these sort of cases because not always chest pain comes very acutely. Sometimes it can be a long standing history as well. Like this case, 50-year-old man is in your GP clinic complaining of chest pain and dizziness for the last 1 month. Whenever you get this sort of case, make sure that you understand that this could be a case of angina due to anemia, because if it's a MI, it should not persist for like 1 month. Okay, it could be it could be obviously angina, but you need to find out why this patient having angina. Not always it's due to like fatty substances in the coronary arteries. Sometimes there can be underlying cause as well. So your task is to do history, PFE, diagnosis, and management. Positive point in the history in here is patient having on and off chest pain, which is 5 to 6 by 10 in intensity, constricting, retrosternal, comes and goes, precipitated by effort, relieved by rest, also radiates to the neck, jaw, and arm, which means it's typical of angina pain. Patient also feeling dizzy, so especially from standing, especially when they stand from sitting or lying position. Is a smoker for the last 15 years, alcohol for 10 years, normal cholesterol, healthy diet, no other conditions. No history of a stroke or heart attack. So only thing that you have found out that this patient having a angina kind of chest pain and also weakness and tiredness, especially dizziness. On physical examination, you found patient is pale. So that's why we always put pickled, remember? So that even if we miss something, pickled will at least pick pallor. Okay, so that's why it's important. When you get pale, you should immediately think that if it's a pale, that means patient having anemia. So obviously, when you check blood pressure, anyone having dizziness, you should always check blood pressure in both standing and sitting position. So that's why you ask for both. So I would like to know the blood pressure in both standing and sitting position. Now you can see 180 by 8, 120 by 80, 105 by 80. It's not very significant postural drop, but still there is postural drop. So this was sitting position, this was standing position. Normally, if systolic is more than 20, then you can think about postural drop. But it's still this one, there is postural drop. Pulse rate is 90 and regular. Others are all normal. In case of anemia causing angina, you need to also try to find out if there is any blood on DRE. Because most of the time anemia happens due to GI tract blood loss. So always try to do a DRE to see if there is any blood. Okay, so that should be your main thing in here. You need to remember these things, that you need to ask for pickled, mainly pallor. You need to ask for postural drop. You need to ask for blood in DRE. So this is one of the things that we haven't done so far. Now in this case you have to do it. Now, in this case, good question. So, do we follow the same chest pain resuscitation thing in here? It totally depends. You have to say some of the questions to the patient first. So, this patient having chest pain for the last 1 month. You have to ask, John, I'm really sorry to see. I'm really sorry to know that you are having chest pain for a month. How are you feeling today? Are you having any chest pain now? If the patient says that they are having chest pain now, then you need to go into that. Can you tell me how severe is the chest pain in a scale of 1 to 10? If the patient say like 8 by 10, having chest pain right now, then you need to follow the same protocol. Most of these cases, patient will say the patient not having chest pain right now. Okay, because this is how this case is supposed to. So start with the chest pain question. Ask the dizziness question also. So can you tell me more about what do you exactly mean by dizziness? Have you ever lost consciousness? Any relationship with the change of your position from sitting to a standing position? So mainly dizzy questions you need to ask. Can you please tell me more about what do you exactly mean by dizziness? Okay. Do you have you had any loss of consciousness so far? Do you get dizzy when you change your position? Only these three questions is fine. You don't need to go for pre-syncope, syncope, post-syncope. No need in here. Associated symptoms, same. So ask about shortness of breath, racing of the heart, nausea, vomiting, all those questions. Ask all the differential diagnosis, same like before. When you come to the anemia, then you need to add some of the questions. So patient will say, yes, I'm feeling quite tired these days. Whenever patients say that, you should think that this could be anemia case. So you say, do you feel tired and weak these days? Yes, doctor. Then you need to go in detail about why this patient can have anemia. So it could be dietary problem, could be loss of blood from anywhere, could be medication induced like NSAID, could be cancer as well. So, do you take healthy balanced diet? Yes, doctor. Any loss of weight, loss of appetite? No, doctor. Sometimes this patient can have loss of weight because most of the time this is related to colon cancer. Any change in your bowel motion recently? Have you noticed any change in color of the stool, especially any black stool? Any history of heartburn or indigestion? Now, this case particularly, this is a like 50-year-old patient. They are, if they are having anemia, most likely they will have iron deficiency anemia. And that's very, very important to rule out colon cancer in this patient if someone having anemia in this age group. So that's why it's very important to ask about any change in weight, any change in appetite, any change in bowel motion, any change in color of the stool. Okay, these are very, very important questions. After that, finish with past medical history, family history, SADMA. In the past medical history, make sure you ask directly about any history of peptic ulcer disease. And in the medication, especially ask about using any aspirin or NSAID. PEFE, same like before, general appearance, pickled, you will get pallor positive here, vitals and BMI, in here postural drop can be positive. Ask for CVS. In here, you have to actually ask CVS, abdomen, respiratory as well. And you can also ask CNS because this patient feeling dizzy. But mainly do not forget about checking the abdomen. Do not forget to ask for DRE. Why we are doing DRE? Because it could be occult bleeding. Sometimes if a patient having lower GIT bleeding, you can get some blood in your examining finger. So you explain in this way, from history and physical examination, most likely you are having a condition called angina due to anemia. Do you know what it is? No, doctor. Well, let me discuss it in detail. Anemia means lack of blood in your body, which is most likely due to loss of blood from your back passes. When I examined you, I found some blood in your back passes as well. Please don't get scared. Now, as your body doesn't have enough blood supply, your heart is not getting enough blood, and that's resulting in chest pain and discomfort, which we call an angina. Right now, I need to admit you to the hospital because you might need some fluids. I will also discuss it with my senior, and also we will involve a bowel specialist and a heart specialist for further investigation and management. Remember, in this case, cardiologist and gastroenterologist both should be involved. Further investigation might be done according to their decision. In the meantime, I will do some basic blood test. So full blood inflammatory marker, ECG, iron studies, blood grouping and cross-matching, liver function, kidney function, blood sugar, and cardiac enzymes. Specialists might also order endoscopy and colonoscopy to rule out any nasty changes in your gut. In colonoscopy and endoscopy, usually they insert a flexible tube into your mouth to look into the stomach for any nasty growth. Also, in colonoscopy, they insert a flexible tube through your back passage to look into your gut. Please don't get scared. This will be done making sure you don't have any pain and you will be put under sleep, which means anesthesia. But I want you to know that this is very important because in your age group, if you are losing blood in your gut, we should always rule out any possibility of nasty growth, mainly cancer. Once we do all these investigation, then a specialist will manage you accordingly. Please don't get worried. You are in the safe hand and we will monitor you and we'll try our best to make sure you get comfortable again. All right, so that's mainly angina due to anemia case. Any question you guys are having at the moment? DRE is the digital rectal examination, Dr. Fernando. You Now you don't need to do DRE on the patient, you'll just ask it. And this is an online exam, so there is no way you can do it DRE on the patient. Previously, we used to do it mainly on the mannequin, but now mannequin is also outdated, right? So Now it is only online. So we'll finish it here tonight. We have one another case, two cases actually, CVS risk assessment. In the next class, we will start with those two, and then we will do some role play on the cardiology. All right. So please make sure you prepare all these things that we have done in these two class so that you can do some role play with me. So this is very important. The next class will be totally role play. So make sure you finish these cases. So are you guys understanding what I am saying, or are you guys enjoying the class? I know that it's difficult to concentrate after 1 hour to 1.5 hour, but if we just take 1 hour class, this course will go on for 2 years, I think. So I know this is a little hard to concentrate, but we need to at least take class like at least 2 hours. Otherwise, never ever we can finish it. There is a lot and lot to discuss. So, Dr. Sanjida, when we ask about stability of patient to invigilator before introducing myself to patient, no, you should always introduce yourself to the patient first, give the painkiller if the patient having pain, then go to the invigilator for stability. So you should never ever go to the invigilator before introducing yourself to the patient. It's very, very important. So as you know that these are the free 2 week sessions going on at the moment. So any of you wants to join our course, make sure you already email us or message us to our messenger that you want to join so that we can start the process now. Because if you delay, then there will be delaying with registration and also starting you on the software. All the notes will be uploaded in the software, all the videos will be uploaded in the software. So once you are done with the payment, you will be added there. Okay, we are not adding anyone until this two weeks free session is gone, and after that we will add everyone. Okay, if you still having any question about our course, make sure you go to the detail of the course in our first aid AMC clinical group. Okay, or you can even ask us to the messenger or email. Will be happy to answer any of your queries. And if you have heard that we are going to do one of the very important thing that I am actually on the way to start that. So we are going to arrange a role play session for everyone in our course. So we have got around 150 or 200 students so far in the clinical. So all those students, we will give them access to do 24 into 7 role play. So we are making a role play platform for them so that anyone available in the Zoom or our platform, they will be able to do role play with others. What happens in this way, everyone in that Zoom, they are following one particular note, they are doing role play with others, and you don't need to worry for like your partner is having a dinner with someone or having a social party. You don't need to worry about it. So you can just come and just do the role play, and then you can go by your own. So it's a very, very good thing that we are going to start. It will be started from you guys. So from this batch. So we are really excited about that. See that how it goes. Okay. So see you in the next class. Make sure you finish all these things so that we can do role play. Have a good night. Bye. Thank you all.